Oh, there we go. Okay, good morning, everyone. Welcome to the debates. I hope this turns out a little bit better than what our commander-in-chief does. Today, I was asked to support operative fixation of calcaneal fractures. Here are my disclosures. I am a surgeon. I like to operate. There is a surgical solution to everything. I have no financial disclosures. I am a card-carrying member of AO, and everyone knows that means always operate. Surgeon's motto, you can't heal without steel. A surgeon is a physician that finished his training. Anybody disagree? All right, these calcaneal fractures are also known as lover's fractures, Don Juan fractures, Casanova fractures, because they're sustained by males that are leaving the second floor through a window when their lover's spouse returns home. What do we know? In 1912, Cotton said, the man who breaks his heel is done. Bankhart in 42 said, the results of crushed fractures of the os calcis are rotten. I say displaced fractures of the calcaneus are freaking bad. Do something, make them better. So these constitute 2% of all fractures. It's the most frequent tarsal bone fracture. It's a disease of young men again. And it continues to present challenges for all that try to deal with them. The anatomy is key here. The tuber is a lever arm for propulsion in the lower extremity. The anterior process carries significant weight. It articulates with the calcaneal cuboid joint. Sustentaculum tali is the fulcrum for the FHL. The facets are very important. They support body weight. You've got all this weight in your body going through these little sets of bones down the bottom. Very exquisite machine. The injury is secondary to high axial energy. Motor vehicle accidents, fall from heights. The primary fracture line results in two fragments, the constant fragment, and the secondary lines run through either two phases and creates significant injury when displaced. So 60 to 75% of these are displaced intra-articular injuries, 25 to 30 are extra-articular. There is a 10% association with spine fractures. So when you see a calcaneal fracture like this, you have to further examine the patient, ask them questions about back pain, get a lateral x-ray if there's a question. We use the Sanders classification that's aided by CT for evaluation and treatment direction. Historical treatment shows that it wasn't until the late 80s that we started fixing fractures. Bernurska, Latournay, Sanders. How can you go wrong with this group? What the heck? They said fix them. Historical treatment, barbaric. Look at this. Smashing people when they're asleep. What the heck? Not good. Treatment options, limited fixation or open fixation. Primary arthrodesis, personally that's something I never do. Amputation, and then non-operative is really small, way down there at the bottom. Here's a Swedish study. It shows after the first year, there's really no difference. But at 8 to 12 years, in this prospective randomized controlled study, there was a significant reduction in pain in the operative group. And beside that, there was a significant decrease in post-traumatic arthritis. Only the Swedes can do something like this. Canadian studies showed that there was an improved outcome in women that were operated on. Who doesn't want to support something where women do well? I mean, what the heck? Surgical treatment. Indications include displaced articular fractures, anterior process fractures, displaced fractures of the calcaneal tuberosity because that eliminates this fine-tuned force generator, and fractures, dislocations of the calcaneus, selected open fractures of the calcaneus. Relative contraindications. Well, in this case, they're relative. We could eliminate the diabetes and the smoking. That's for sure. There's a 90% wound issue when this trifecta is present. But, you know, we were trained to take care of wound issues. We know what to do with that. So here's a guy with a bad calcaneal fracture. Yeah, you know, he's got diabetes. He's a smoker. The good news is he's not employed. This isn't workman's comp. You have to look on the sunny side of things. So Bowler's angle, he killed it, clearly. Smashed the angle of Gissane. A little skin problem, not a big deal. You just wait, watch this thing elevated, compressive dressings, be patient, or wait for the skin to return. You see some wrinkle, green light, go get it. So the goals of treatment are maintenance and support of the lateral column of the foot. That's extremely important. Get that valgus out of there. You want to dynamically stabilize the foundation for body weight and you know, reproduce the mechanical advantage of the heel. Susan, do you want to put somebody in these shoes for the rest of their life? What a fashion faux pas. And these babies are expensive, I'm telling you. So, like Nike, just operate. Or, as we say in the south side of Bethlehem, fix that Mo Gator. And I rest my case. Thank you, Dr. Lanz, for your help with this.
Yeah, I've already lost. That is great. Well, I find myself tasked with the dubious challenge of advocating for non-operative management of this injury and opposing the eminent Dr. DeLong, which I would never want to do. So I'll do my best here and talk to you a little bit about why non-operative management of this injury should be considered. And it's not just non-operative management of the calcaneus, but non-operative management of this patient's calcaneus fracture. And that's where I think the key comes into play in my argument. We already talked a little bit about the magnitude of these operative contraindications in the outcomes of patients with these severe injuries. So this gentleman, for example, has diabetes. He is a smoker. He has all of the sequelae of those disease states. And other possibilities for other patients include immunosuppression, neuropathic disease, issues in the elderly, non-compliant patients, and surgeons with inexperience, or even in those of us that are experienced with tremendously challenging cases that can lead to less than optimal outcomes if you take the surgical route. Operative contraindications have been discussed since we began trying to fix these injuries surgically with gusto around the turn of the century. Again, the triple whammy of diabetes, vascular insufficiency, and smoker representing at up to 90% rate of complications. So why would you want to put your patient through that risk if they already had those risk factors present? If this was an open fracture, his risk would be even greater. And especially with medial, the dramatic medial wounds that they can present with, if the if the grade of the open fracture is 3B, then 77% of those patients will end up with an infection and 46% with BKAs. Now, this is earlier literature. This is 2003, but even with our more recent studies, there's a lot of recommendations leading towards less invasive surgical interventions. I would argue that non-invasive interventions may be key for a large patient population. Even with our most recent literature, the incidence of wound complications associated with the popular lateral extensile approach ranged from 7 to 37%. That's a huge number to carry around with you. And you know the patient sits at the edge of your bed each night. And these things weigh heavy on your soul. Wound complications with the traditional approach have also been associated with a number of factors, including the Sanders classification, the number of residents and surgeons operating in the case, the number of people in the operating room at the time of surgery, and again, with this gentleman, tobacco use and diabetes. So we go into the operating room and it's a big party and everybody's having a good time. I am a surgeon and I too love to operate, but some of the things that we bring down on these people may be put them at a disadvantage more than an advantage. Even simpler things that aren't quite as devastating, like sural nerve injury and tibial nerve injury, show significant percentages in the population of operative patients. So you can avoid all of that simply by not operating. It doesn't mean that you're afraid of the surgery. It doesn't mean that you're scared or running away from the surgery or disavowing the surgery. But you have to make very careful decisions when it comes to this particular patient population. This guy is a surgical risk. Are you ready to assume that risk? You'd better be very sure that you've carefully considered all of your options. There are many different options for treatment, and some of them of the best or most supported in the literature may not be right for your patient at that moment in your office as you make the decision together. So every case has to be assessed individually, and the risks and benefits must be discussed in detail. Sometimes less is more. And we all know that there is no way to avoid all risks. And in some patients, no way to avoid risk at all because you're already starting at a deficit. As a final thought, remember, when you have a complication, it's not you that has the complication, it's the patient. When you're making a decision together, it's not you that's facing the magnitude of that decision, it's your patient. So it's super important to educate patients like this gentleman about their risk factors and the options that they have, including non-operative management. You need to empower your patient. Never talk down to them. Never use terms that they can't understand. Speak in normal language, but engage them and empower them to be an equal partner in the decision-making. The first slide failed to tell you that the gentleman said, "I don't want surgery." And so you need to respect that. And therefore, the answer is obvious, non-operative management. Always start every one of your conversations with a patient that you're thinking about operating on with the statement, "I want to go over your options. This injury can be treated surgically and non-surgically." And if the answer is surgery, you first state that the non-operative management would go along in this fashion, and this is why I don't recommend it. For this gentleman, my discussion would be, your risks are significant, and the outcomes will be adequate, and you're with non-operative management, and it's better than the complications that you face ahead. You have to understand the patient that you're dealing with. Every single surgical decision that you make, and this is just one example, whether you're taking care of this patient, or someone somewhere in between. Heavy is the head, my friends. So as you enter into the operating room, which is what we all love to do, remember, there's a world of sins hiding underneath that vac dressing there, and you do not want to be that guy or gal. So don't operate on this gentleman.
So let's get the ARS question. So actually, can I get the title slide? Sorry, the ARS question doesn't have the whole case. And I just want to say real quick, those were really great. And Dr. DeLong really had me cracking up, almost to tears. That was really funny for some reason. I mean, these debates, I don't think we're trying to say, like, there's a definite answer. Certainly not for the topic in general. Now, I tried to sort of phrase it in a case. But I think that, you know, if you at least understand the extremes and what are the arguments for the extremes, I think that you'll be able to make better, better decisions for your particular patient, for your particular case, because, the answer is going to change based on your case. So hopefully, if that's the expectation, you're not thinking like, well, I didn't really get an answer to this. You're just trying to really see what does the literature speak to in either direction. So let's take a vote on this particular case. Hopefully you had enough time to look at that. I'm going to vote too.
I voted for you.
All right, well, if I'm reading this correctly, operative...
you guys are just trying to be nice.
Operative 30%, non-op 70%. So Dr. Harding is our winner.
I would operate on that in 10 seconds flat.
But anyhow, I think that was a great debate session. Any final comments?
No, just that I think what you said is exactly right. When you do these debates, you're just kind of seeing the broad spectrum. And obviously, they're very extreme, kind of ridiculous, one side or the other. But those arguments that you hear, you can incorporate into your conversations with your patients. All right? That's very important to explain the broad spectrum of their options, even if it's not the path you're going to lead them down.
Yeah, I would say... Am I on? Okay, yeah. In the real world, I wouldn't touch this with a 10-foot pole.
Isn't that funny? When I got the assignment, I thought to myself, they mixed it up because I knew that
you could talk to my residents. Everything has to be perfect. I think calcaneal fracture fixation surgically, the pendulum is swinging the other way. If things aren't right, you actually create more harm than you help with, and it's important to recognize that. It's a very difficult area to work well in, and those of us that have failed know what the consequences are. So you have to be very careful. Doing this presentation today was like me voting for Donald Trump.
All right. Well, I'm gonna.
But wait, I just have to say one tiny thing. The majority of the calcaneuses that I'm fixing now, and we can talk about it with the other people, I'm doing through a minimally invasive approach now, which really is a game changer.
So let's, I'm going to get Dr. Reed's comment, but let's get the next group up. We have the clavicle debate, Dr. Kazanjian and Dr. Fuller, and we can get the title slide, and let's get Dr. Reed's comment or question.
Vote before the debate to see if we change opinions.
We could do that.
My only question was, when you have a discussion with these patients, are you talking to them about like subtalar fusion, perhaps when they're not so damaged and in the future, and are you looking out that as a possibility when you're having the discussion about the potential next sequence?
Yeah, I certainly do. I tell them that this may be multiple procedures. We'll try this first, and then if that doesn't work, there may be other surgeries in their future. I try to do that with everything, not specifically with this.
I do that to every patient with every surgery I do. I tell them these are complex injuries. I have like a whole spiel that I do for my pre-op stuff and the non-op stuff as well, but and everybody's got their own spiel. But you got to say to them, there may be future surgeries. This is a very complex problem, and we take it step by step.
Last question? Yes.
I have the utmost respect for Dr. Harding and Dr. DeLong. not feel comfortable with the calcaneal fracture operating until he used 400. Then he started to feel comfortable doing that. So that's something we should all take. And that's DeLong. I love you very much, but as the old saying goes, there's not one injury or one illness that surgery can't make worse.
Amen, brother.
Here, here.
All right, great. Thank you again very much. So Dr. Fuller had a great suggestion. We'll take a vote before and after, and just kind of see how our moderators, our panelists, are effective in changing your mind. 36-year-old male, fall playing tackle football on the weekend with his buddies. Isolated injury, no medical problems. Right-hand dominant, works as an accountant. So let's have the ARS clavicle, operative or non-operative. Again, 35-year-old male, weekend athlete. Accountant. Non-dominant side, I think it was. 50-50. All right. So let's see what we got. All right. So it looks like we have Dr. Kazanjian coming first.
That's it. That's it.
Oh, that's
it.
Okay.
I used your
that's
slide.
It. All right. Sorry.
Because that's what the lecture's about, using this slide. Thank you, Dr. Rahman. Thank you once again to the co-chairman for allowing me to participate, and for Temple University. It's been like the 4th or 5th year I've been part of this program, and it continues to grow. Actually, I'd like to thank Dr. Fuller. He was initially doing operative, and I had non-operative, and he switched his stance and allowed me to win this debate. So I'd like to thank him very much for switching. So why fix this fracture? 36-year-old, weekend warrior, plays football. He's an accountant. It is his non-dominant arm. One, he's young. It's tax season. He's very busy. It is a middle third Z fracture. This is the fracture at risk, and looking at all the literature where we talked about fixing fractures of the clavicle versus not. The literature is going to bear it out, old and new, and I'm going to prove it. So when I started training, which wasn't that long ago, I did my residency from 99 to 2003, even back then, our attendings would say, oh, you have a clavicle fracture, you put one piece of the clavicle on this end of the room, put one piece of the clavicle on that end of the room, they're going to heal, they're going to do fine. Well, in literature back in 97 to 2006, it proved that non-operative treatment of clavicle fractures gave poor results, had sequelae, and had deficits that were not seen traditionally in review of clavicle fractures, which started a revolution in evaluating clavicle fracture treatment, whether it be non-operative versus operative. So why do we operate? In a landmark study by Robinson and Court Brown in JayBJ's, they studied 868 clavicles. An overall non-union rate was 4.5%, but what they delineated was a specific fracture, the middle third Z-type fracture, the Z fracture pattern with butterfly fragments that had an incidence of 21% non-union. So they postulated that the potential of fixing this type of fracture would, one, decrease the risk of non-union and malunion, which were symptomatic and problematic for patients who sustained middle third clavicle fractures. So the study that started it all, the study that started the snowball effect of starting fixing all clavicles and industry getting involved in clavicle fracture fixation, was the study out of JayBJ's, the Canadian study, which evaluated non-surgical treatment of middle third clavicle fractures versus plate fixation, superior plate fixation of middle third clavicle fractures. What they found all across the board was that non-union rate was substantially lower. Symptomatic malunions were 0 to 9. Operative patients were more satisfied with function in cosmesis. Healing was substantially better and a lot earlier. And surgery all across the board, early and late, had better constant and DASH scores in patients that were fixed with superior plating techniques. So if you want to look at Cochrane reviews, the Cochrane review back in 2014 out of CORE, surgical versus conservative treatment of clavicle fractures, showed to date, all of the randomized trials have found that 15 to 20% of patients develop non-union with non-operative management, surgical fixation with superior fixation, nearly consistent achievement of union, and a low frequency of major complications and satisfaction in patients who had surgical intervention. So that's a study from 2014, Cochrane, who cares? What about some of our newer literature? It's been borne out in the past, and now it's been borne out now. 2014 JSES, this is not coming from the Journal of Indian Physiatry. This is something, these are good literature, good articles out there. Meta-analysis, 7 studies, ORIF versus non-op. ORIF was found to be superior in all randomized studies in the meta-analysis. They had a lower non-union and symptomatic malunion rate. They had better DASH and constant scores. They had fewer complications and a better appearance, and patients were much more satisfied. And in their subgroup analysis, they found that the patients that underwent superior plating were the ones that had all of these results due to fixation with superior plating. What about more studies? Another meta-analysis out of JayBJ in 2017. 6 randomized control studies, less non-unions, secondary operations for adverse events in ORIF, improved DASH and constant in ORIF. Secondary operations were common in both. So in patients that were treated non-operatively, secondary operations were common. And the most common secondary operation for patients who underwent ORIF was elective hardware removal. So if you eliminate elective hardware removal, secondary operations were much higher in patients that underwent non-surgical treatment of middle third clavicle fractures. So more recent randomized controlled trials favoring ORIF, the Clavicle trial out of Netherlands in 2017, non-union rates at 9 months, 0.8% for ORIF, 11% for non-op. DASH and constant scores were better early and late for ORIF of the clavicle. That shows more data supporting ORIF. So we're seeing a pattern here. Better constant scores early, better DASH scores early, better constant scores late, better DASH scores late. More satisfied patients, higher rates of union, less adverse events with ORIF of this type of fracture. So people will say, if you operate, you can get a complication. There's nothing, if you use steel, you're going to get something wrong. Too many reoperations for ORIF or complications. Well, here's another study out of JSCS. It was a database analysis done by Brian Feely and his group, and also a complementary analysis of what happened in their institution. They found that almost 8,000 patients underwent ORIF from 2007 to 2011. Their results from their institution kind of paralleled what they found from the database review. 12% required hardware removal, only had a 1% non-union rate. Females were 4 times as high to remove the hardware. Excellent outcomes were noted in all patients in regards to DASH and EQ scores. And this guy's a dude. He's not a female. He's not going to want to get his hardware taken out. Another reason to not have another operation. So ORIF does better early and does better late. So Journal of Clinical Orthopedic Trauma, 50 patients followed up for 1 year, ORIF with superior plate versus non-op. ORIF at 1 year, 76% excellent, 16% good, and 8% fair. Look at the non-op, 28% good, 32% fair, 40% poor. None of them were excellent. Need I say more? So is it cost effective? Absolutely. Journal of Orthopedic Trauma, the cost effectiveness was shown acutely, late, and even after 9 years to show that ORIF of the clavicle is very cost effective in treating patients versus non-op. Is it still cost effective? JSCS in 2013, clinical and financial comparison of OR versus non-operative treatment of displaced clavicle fractures, less chronic pain, less weakness, less loss of motion, fewer non-union. This is really important. Missed fewer days of work, 8 days versus 35 days. Cost was $12,000 for operative patients and $18,000 for non-op patients. So you can't tell me that if you operate on somebody, it's going to cost somebody more or going to have more complications. So it's even cost-effective and better than workman's comp, which is unbelievable. So JSCS, 76 patients total, 42 non-surgical and 34 surgical. Followed up with time to work and healing at CT scans. Return to work in ORIF was 3 months. Non-op was 3.7. Bone healing was 81% at 3 months via CT on the ORIF and 16% in non-op. The constant scores were higher in ORIF at 6 months and 12 months in work comp patients. Unbelievable. So return to sport. Out of Birmingham, everyone gets back to sport down there 100%, but even in high active athletes that were young, they got back 30 out of 30 at 3 months to playing sport with superior plating. NFL football, landmark article, Patrick Connor out of Ortho Carolina, fixed fractures in NFL football players. They found that 13 displaced fractures were treated, half were treated ORIF, and 7 were treated non-op. They found that 4 out of 7 refractured in the non-op, and 1.5 seasons were missed in patients that underwent non-op treatment of clavicle fractures. Conclusion, displaced fractures of the middle third of the clavicle underwent ORIF in NFL players. He's not an NFL player, but he is a weekend warrior. Malunions are no joke. Oh, they heal, they do great. Many studies have shown difficulty with overhead function, pseudoaneurysm, thoracic outlet syndrome, Plus, if they are dissatisfied with short clavicle syndrome, the surgery is not easy. Sliding osteotomy here, bone grafting, superior plating, big operation, big secondary operation, as opposed to a very simple operation in an acute fracture. So this x-ray in this patient is not a true film. He is laying supine, his arm is splinted. So it looks like it's really non-displaced, but this is a Z fracture. There's 2 butterfly fragments, and if he were to sit up and let gravity assist in this fracture, he will spring like this, he will tent his skin, he'll be very dissatisfied with non-surgical treatment. So my indications for surgery for ORF or midshaft clavicles are 1.5 centimeters of shortening in the Z fracture, 100% displacement. I'm very wary of the Z fracture. I accept less displacement in collision athletes. Is he a collision athlete by name? No, but he might want to play rugby and football on the weekends. Lengthy time for a union with non-op treatment. Those patients who have severe pain and skin tenting and want to get back to work or activity sooner are the ones that I consider surgical intervention for. Now, don't get me wrong. I don't operate on them all. Here's a 75-year-old pastor of mine. This is his dominant arm, sustained a Z fracture. I recommended non-op. These are his initial films, very similar to the films that we saw from this patient who's 35 and an accountant. At 5 months, he's healed, he's happy, but it did take 5 months, and he is 75 years of age. This guy's 36. So here's a great study from the Journal of Sports Medicine, surgical versus non-surgical treatment for midshaft clavicle fractures. Systematic review and meta-analysis shows that surgical treatment, fewer non-unions, fewer malunions, and accelerated return to work. The results of this meta-analysis favor surgical treatment. However, it should be kept in mind that this is patient-specific and should be taken into account. The final decision for surgical or non-surgical treatment should be based upon shared decision-making between you and the patient, which is what I do every single time. Here's a 31-year-old patient of mine, fell off of a bike, initial ER films. Sat him up, he sprung, he was unstable, we fixed him, double plating, he loved it, he's doing great. So in conclusion, for minimally displaced middle third clavicle fractures, non-operative treatment is preferred, and it may take longer than expected to heal, and I elucidate that to the patients. For displaced fractures, this type fracture, ORF is preferable in select patients. Return to activities are variable within 6 to 12 weeks. The most common complication or secondary operation for ORF of the clavicle is hardware removal. I just don't take them out. And if I do, I wait at least a year. ORF is superior to non-op all across the board in regards to DASH, constant scores, cost, patient satisfaction, back to work, so on and so forth. So just fix it, especially this one. And with that, I thank you.
Thanks, Sockem, for the chance to talk again. And it's great to be back here with a good audience. And Jack just quoted a lot of interesting literature, on this approach of just fix it. I think we're tending toward this. He talked about the key decision makers as being the patient and the physician, but let me start to introduce the idea that there may be some other variables as part of this decision too. And the scores aren't the same. He quoted some articles, went through them very quickly. But the truth is the scores kind of converge with time, and here's the case. I don't need to go over it again. Let's talk about how we make a decision. I went to a liberal arts college, and I took a philosophy course, and part of that philosophy course was how to make decisions. And we talked about a prisoner's dilemma, should I plead guilty or non-guilty? In this case, we're choosing between non-surgical and surgical care, but we make decisions all the time. We may do this consciously or unconsciously, but in our minds, we have a decision matrix. Here's somebody buying a car. They're trying to choose between these 4 cars. New Chevrolet, used Mercedes, pre-owned Ford, Uncle Henry's car. And then you have to look at your variables, or what are your options, or what are the decision-making elements, and these need to be looked at independently. In this case, cost, reliability, efficiency, and desirability. And I'm going to apply these things to clavicle, but each column should add up to 1. So if you look at cost, Uncle Henry's car is the cheapest, 0.54, so it gets the highest rating. The other ones are less expensive, and this is just distribution of cost. Reliability, the most reliable, for some reason, the used Mercedes and the pre-owned Ford. And just each column always has to add up to 1, and then you go across the row and add them up, and whichever one's the highest, that's your choice. This is how you should make decisions. Otherwise, you get bogged down in emotional stuff, or you can choose to weight one column very heavily. If you put all your weight in non-union, of course you're going to have surgery. But life isn't that simple, and I think these variables need to be looked at independently. And who's making the decision? Jack suggested that it's just you and the patient. But maybe there are other people making decisions. Maybe the hospital is. Maybe industry's contributing. Maybe the insurance company has something to say. Maybe society has something to say. And who gets the biggest say? If society is, maybe cost is more important. And if the surgeon is, maybe his pocket is part of the skin in the game here. Maybe he owns a surgery center. Maybe he's got an opening in the schedule. Maybe he likes surgeries. Dr. DeLong suggested a couple talks ago. I think some of the variables in this relate to outcome, and Jack talked a lot about outcome. Time to recovery is important. Variability in terms of predictability. What are our complications? Cost and desirability. And for patients, these are what they want. They want a full recovery. They want it fast, right away, 100% predictable, no complications, no cost, and they want a choice that they really want. And the closer we can get to these, the better. So if we create a matrix for clavicle, it might look something like this: non-surgical and surgical, and these are the things I just talked about: outcome, time, predictability, cost, and desirability. Each column has to add up to 1. Let's look at functional outcome. The clavicle study from the Canadians was already mentioned. It was in 2007, and it started to suggest that outcomes were better in the surgical group. Here were their 52-week scores. Jack didn't show you the graphs, but he showed you some numbers. But in just about every one of these studies, everything converges. Their constant scores were converging, but there was still a little gap. And you got to remember, their non-unions were still living in the non-surgical group, which can be easily fixed. The DASH scores converge, but there's still a little gap at 52 weeks. So in England, they said, we're going to redo this study, but we're going to try and do it better. We're going to put more patients into it, almost 3 times the number of patients. 300 patients randomized, 2017, JayBJs. And Jack already quoted this one too, but he didn't show you the data. By 9 months, the groups are equal, constant scores. They're almost equal by 3 months. DASH scores, equal, 9 months, almost equal at 3 months. And their conclusion was that the outcome of a united midshaft clavicle is good regardless of whether the patient was treated operatively or non-operatively. And both are safe, few substantial complications in either group. Let's talk about the complications a little bit. You know, it's easy to harp on non-union, malunion, which are both very correctable through a surgery. There's also this aesthetic issue. Do you want a bump? Do you want a shoulder that droops in a little bit? And I'm not trying to minimize these things. They are complications of this treatment. But there are also significant complications of surgical treatment. You can still have a non-union or a malunion with surgery, infection, which can be horrible, osteomyelitis, multiple surgeries, backs, rotation flaps. Chest wall numbness is not trivial. The scars are ugly. So you can still have this aesthetic deformity, and others. You can have a perioperative complication, DVT or whatever, add your own anesthesia complication. Cost. This is the bill that the insurance company will see for surgical care, $14,700. Non-surgical care is embarrassing, costs $3,000, because you can give these people a sling and say, see me in 6 months. The cost for non-surgical care should be close to 0. But the cost for surgery is over 3 times the cost of non-surgical care. And this is just the bill the insurance company sees. This does not consider work. And so there are some articles that look at out-of-work issues, but this guy doesn't have to miss any work. He's an accountant. In fact, he'll miss more work having surgery, because he's got to have a day of surgery, couple post-op visits, a day of pain. So he's going to miss more work with surgery. And if you're an epidemiologist looking at public health, you can do the math. You know, we have over 300 million people. The incidence of clavicle fractures is 5.8 per 10,000. If we start operating on all these clavicles, we're going to spend $2.8 billion on fixing clavicles in our country. We're already spending 18% of our GNP on healthcare, and our goal is to decrease this risk while maintaining quality, maintaining good outcomes, keeping in control on complications. And granted, not every clavicle is midshaft, not every is displaced. About 80% are midshaft, 50% of those are displaced. Desirability. Nobody wants surgery. Every patient will tell you that. Isn't there a way to treat this without surgery? So desirability favors non-surgical. Who wants surgery? So if we go back and look at this guy and try and put these things in a grid, because it's easy to get lost in the emotion of non-union and all this kind of stuff, work. But, you know, why are we talking about NFL players? This guy doesn't play in the NFL. Non-surgical and surgical, the outcomes are about the same in about 9 months. If you look at almost all the studies, maybe there's a little bias. In fact, most of them show a little bit early. Functional outcome is better early, but at 9 to 12 months, they're almost all about the same, particularly the later, larger studies. Time investment. The recovery is a little bit quicker with surgery, no doubt. And that's why if you're an NFL player or if you're producing an income of maybe $20,000 to $30,000 per month, you can recoup that $14,000 cost by getting the person back into the workforce quicker. So surgery related to time investment's a little bit quicker. Predictability, about the same amount of complications in either group. Well, you know, pick your complication. The non-surgical group, a little higher, malunion, non-union. The surgical group has all the surgical complications, second surgery, infection, scar, those kind of things. Cost, I just mentioned quickly. Cost certainly favors non-surgical care unless you're in a high-producing income job. NFL football player that Jack mentioned. If you're in workers' comp and you're producing a lot of revenue for that job, then maybe you think about surgical care. Desirability, certainly surgery is the less desirable choice. Nobody wants surgery. And so if you take the emotion out of this and stop harping on a single thing and look across the board, which is your better choice for a mildly displaced clavicle fracture, if you add things up in the top row, by far it exceeds the surgical choice for this injury. So looking at all these things, functional outcome, time investment, predictability, cost and desirability considered together certainly favor non-surgical care, but you can bias this argument looking at a single argument and making this an emotional argument. Or the argument can be perverted if you fail to consider all the players. If you're just looking at what's the best choice for industry, well, then you want to put as many plates as possible. What's the best choice for the physician who likes to operate, who makes more money operating? You get about 5 times as many RVUs. And if you own your own surgery center, if you own your own therapy facility, if you want to do more x-rays, then yeah, do surgery. Put the physician at the middle of this choice. So the choice of non-surgical care also is not singular. You can also convert it to surgical care. If the person is getting a delayed union, a non-union, a malunion, they easily flip over to surgery. And so I would advocate in this patient with a mildly displaced midshaft clavicle fracture that looking at all of the parameters here, all the variabilities, the choice is non-surgical care, which you can easily convert over to surgical care. It avoids the costs and complications of surgery. For this patient who will miss more work with surgery, he'll miss less work without surgery. So he'll miss no work, and you can expect an excellent outcome with both choices. Thanks.
All right, thanks. There's our case again, real quick. 36-year-old male, right-hand dominant. It's the left side. Let's take a vote. ARS. So it's pretty fun when the panelists completely don't believe in what they're arguing for, like the last session. But I think it's also pretty cool when clearly there's some passion behind the decision they're promoting. So we were 50-50, or I would say 49, maybe 51 before. So it looks like non-operative, 60%. So that would be Dr. Fuller is our winner.
Well, it's because I went second. There's a bias to people who speak secondly.
True, true. Yes, we sort of did that with the whole session here. Any final comments or questions?
He'll have no problem coming over the bridge when he gets his non-union, and I'll take care of him.
What about the fraction of the outer end of the clavicle?
It's not
so
part of
lateral or distal clavicle fracture?
This debate was for this specific fracture. Distal third clavicle fractures are a different animal. They have a much higher rate of non-union, but I spoke about this last year. The distal third clavicle fracture, once again, is depending upon displacement, patient factors, age. I tend to treat, most distal third clavicle fractures that I see are in the elderly population. If they do occur in the younger patient population, they're typically displaced with ligamentous instability, which require fixation, but it all depends upon the patient, the personality of the fracture and the patient itself. So for the middle third clavicle fracture, which was this argument, I still would operate on this gentleman, especially with instability.
Is this the one which you plated or a screw?
I plate these, superior plate, sometimes double plate.
All right, sounds good. I want to thank the panel again. And we'll have our next panel come up. This is a tough session to keep on time. I apologize. Trying to squeeze in essentially 6 lectures with a little bit of discussion maybe is a bit ambitious. But this is our last debate, so we will have the slide first. Here's a 31-year-old female, fall down the stairs after drinking, isolated injury, radial nerve is intact. The patient is left-hand dominant, works part-time in retail. So there's our case. Dr. Brady is going to tell us why we should fix it.
Are we voting first or no?
Oh, I'm sorry. I forgot about that. Let's take a vote. Operative, non-operative. 31-year-old, dominant arm, fell drinking, is working in retail. Operative or non-op? I'm not going to sing, Sue. You just pretend there's some music playing. All right, so it looks like 63% non-operative, 38% operative. Dr. Brady's going to try to change your mind.
Hashtag winning.
Okay, so I'm not going to have a whole lot of primary literature to talk to about this case, but we're a bunch of orthopedic surgeons and we're a bunch of orthopedic residents, and we're learning how to operate on people. I think there is definitely a role for non-operative treatment in many things that we do, but sometimes we're not the bad guys, and actually offering patients operations is actually a good thing to do. I'd like to argue that for humerus shaft fractures, operative care is conservative care. So how I would treat this, this x-ray looks exactly like a patient that I treated about a week ago, same injury. And the treatment I would offer for this is 7 to 10 days of splinting. That's what they get from the emergency department until their first follow-up with you. Take them to the outpatient surgery center or in the hospital at outpatient department, regional anesthesia, no post-operative splinting, immediate rigid fixation, immediate shoulder and elbow range of motion, back to work in less than a week, x-rays at 2 weeks and 2 months, and then they're on their way. They may or may not need physical therapy. So why do we think about operative treatment? Predictable union rates with operative treatment, although we can argue that there's predictable union rates with non-operative treatment as well. There is a low incidence of complications, and you might have to just decide what type of complications you're willing to deal with. I would say that most of us surgeons are comfortable dealing with incision site infections and complications such as that, because we can treat those with antibiotics, or we're comfortable doing secondary debridements to fix that problem, but we may not be as comfortable dealing with pressure necrosis issues or ongoing non-union and fracture instability and pain over time. We can limit the need for splinting, casting, or bracing. The patients are absolutely more comfortable. There's less need for the doctor-patient interaction. Not that you don't want to talk to your patients, but I don't want to have to tell my patient, and the patient does not want to have to say, oh, you're going to come see me today, and then I'm going to give you a prescription for a brace, and you're going to go get a brace put on, and then in a week you're going to come back, and then you're going to take an x-ray on the brace, and then we're going to tighten your brace, and then you can't sleep, and then you got to see me in another week because it might start displacing, and we want to make sure it doesn't displace, and then at 6 weeks you're going to come back, and I'm going to yank on your fracture under x-ray to see if it moves, and if it moves, then we'll have another discussion about whether we should fix it or not fix it. Why don't we just fix it? Pain control is more reliable and immediate, less risk for unrecognized skin compromise because you're not hiding the incision in a brace. Operative care for humerus fractures is conservative care. So we know that there are acceptable limits of reduction that you can have in humerus fractures. Humerus fracture is near your shoulder. Your shoulder is a very mobile joint, so you can take a lot of deformity. And Iscosmesis is not necessarily an issue if you have a mal-reduced or a mal-united fracture. However, we know that surgical treatment does give better alignment, and in today's day and age, patients want everything perfect. Range of motion at the elbow is generally not decreased with non-operative treatment of humerus fractures because we can start, and we actually should start, range of motion of the elbow immediately after treating humerus fractures in a fracture brace. However, we should not start shoulder range of motion until we have a fracture which is starting to show some good healing. So ultimately, patients are shown to have less shoulder range of motion in the long run. We all know how to deal with surgical site infections and surgical site complications. That's what we're training to do. We hope we don't see them. We know we're going to see them with any type of surgery we do, but we know how to treat an incision line complication. However, if in 2 weeks when the patient comes back to see you, you see skin that looks like this with pressure necrosis that may or may not go on to full thickness skin loss, and now you've taken a closed fracture and made that an open fracture, which is a relative indication for doing surgery, do you want to operate through this skin? I would say no, you don't. Do you want to have to involve plastic surgeons in order to help take care of this patient? Patient compliance is an issue. So patients want everything perfect. They want it perfect right away. They don't want to have to put on a bulky brace. They don't want to have to do office visits every week for the first 3 weeks. They don't want to have to sleep in their recliner because their arm moves every time they lay down. Rates of nonunion are similar, anywhere from 2 to 10% with operative or non-operative treatment. There's a study by Driesman that shows that if you stress your fracture at 6 weeks, motion at the fracture site at 6 weeks predicts non-union. How many people are comfortable taking their patients into the x-ray room just in your office and stressing a fracture to see if there's gross motion at 6 weeks? That seems cruel and unusual. And then revision surgery is difficult. So this is an 85-year-old patient who I saw who was treated non-operatively in a humeral fracture brace for 2 years. And finally came in to see me after surgery and said, there is really nothing else we can do. But 2 years later, she has gross motion at her fracture site. She's miserable. She can't move her shoulder. She hasn't moved her shoulder in 2 years, so she's got an extremely stiff shoulder. She's got some rotator cuff arthropathy. And you look at this and you say, oh, that should be a fairly easy fix now. You know, we can take down the non-union and compression plate this. But that's technically difficult to do. If we fix this in the beginning, then we know where all of our neurovascular structures are. We know that whether we go anterior or posterior or lateral, we're going to be able to find the radial nerve. It's not going to be encased in a bunch of scar tissue. When you're doing this a year later or 2 years later trying to treat a symptomatic non-union, then you don't know where your radial nerve is. You don't know if it's encased in scar tissue. You're really hesitant when you're doing your operative takedown of this non-union. You can do it, but it's hard to do. Why don't we just do this in the beginning? I think the patients would be much more happy. So surgery for humerus fractures, in my opinion, is conservative care. And that's what we're always taught to do, offer the conservative option first. However, surgery must be done correctly. We have to adhere to appropriate fracture fixation principles so that we do not create our own non-unions and soft tissue problems. So if you have short segment fractures, then you need to do lag screw and compression plating. If you have long segment fractures or more comminuted injuries, then you need long constructs in a low strain environment. So this is an issue where there's a comminuted fracture treated with a short segment internal fixation on the medial side that the plate was put. Predictably, that's going to fail because the principles were not followed. But if we follow the principles, reduce the fracture, get some interfragmentary lag screws, and bridge and span the most areas of comminution, then we can get predictable healing. Operative care of humerus fractures is conservative care. If patients are more comfortable, we're going to get more predictable healing with better alignment and range of motion, which is what we ultimately want. We want the best outcome for our patients. You get predictable healing. You limit the fracture disease of osteopenia from disuse, from stiffness and skin compromise, from putting a brace on and squeezing it for 6 to 12 weeks. Surgical complications can be eliminated or limited with meticulous surgery. And if you're not comfortable with this conservative measure, then I would say refer it out to someone who is, but you are still acting in a conservative manner by treating your humerus fracture patients with surgery. Thank you.
Thanks, everyone, for sticking around. We still have a good crowd on a Saturday morning. And Sockem for keeping things going for 10 years. Without a doubt, he's also put me in, thank you. But other commenters made a choice. If we get not stuck, assigned a topic where takes you out of your element. And I think somebody mentioned a suggestion in 2016 to have debates because I was intrigued with this whole political thing going on in 2016. That was me. And here I am. We're doing debates. All right. I'm in charge with the debate of the humerus fractures. Here's our 31-year-old female with a fall downstairs after drinking. Isolated injury. Isolated injury. I would describe this as a low-end injury. It's not a fall from a significant height. It's not a motor vehicle accident. Radial nerve is intact. Described as a left-hand dominant female working part-time in retail. I'm Dr. Craig. So I was looking at this and thinking to myself, well, you know, we're looking at an x-ray. This is a 31-year-old female, and I'm married with kids, and I don't really know a lot of 31-year-old females, so I Googled, you know, who's a 31-year-old female? So this is LL, works part-time, pretty much, and publicly available data. Date of birth is 7/2/1986, with this left arm closed, neurovascularly intact injury. If you want to code it, it is either a non-displaced spiral fracture of the shaft of the humerus, left arm initial counter for fracture when you see her in the office. When I look at this, We are describing as the dominant arm. I don't think that plays a role in my discussion of like, oh my gosh, it's your dominant arm. You have to fix it. And I'd say, no, it's your dominant arm. We can overcome that. I write right-handed. I throw left-handed. I can use both hands. It's well aligned, certainly within acceptable limits, which were discussed. I'll bring that up as well. Arm appears not large, right, in this circumstance. I put the orange line there because that's where my brace, that's the upper limit of a brace that's going to go on. That's where I kind of look at these fractures. Can I brace this fracture? This is the case we're being presented. Radial nerve is intact. People argue like, oh, the radial nerve's out, you have to explore it. This is not this case. This radial nerve is intact. This whole case here appears amenable to bracing. If we look at the whole situation here, going through some epidemiology, what do we do with non-operative treatment, and so forth. Epidemiology, it's interesting. It came out in 2006, I believe, from Stockholm. They keep track of their patients. The majority of these are going to be female. Interestingly, the majority, well, 52%, are on the left side. Simple falls. This is our patient. Unlikely to be open. And an 8.5% radial nerve palsy. Again, not our patient, but this is a low energy fall, female, on the left side, very common injury to occur. Anyone who can sit upright, we're all a bit of bipeds, we stand and sit all the time. You can maintain a semi-upright position during early treatment phase, you can have a brace or a splint applied. It's a closed fracture, isolated fracture. So is cosmesis important? Well, how big do you want the incision to be? Or as Dr. Followup pointed out, like nobody really should want surgery. So in this patient who's going to consider, further part-time work down the road, maybe they don't want a big incision on their own. And the arm is thought to accommodate these degrees of angulation and displacement. There's not a randomized prospective trial that's going to show you, well, we're going to randomize everyone to 1 centimeter, 2 centimeters, and 3 centimeters displacement and find out what happens. This is all just a retrospective analysis, 50 years ago, looking at, well, how much they accept and how much did I think, because some things were more dogmatic back in the 60s, and it worked. But we've seen this in practice. Treat them closed, they go on to heal. People accept a mild deformity radiographically within their arm, but clinically and functionally doesn't lead to very much. Really, it's simple. You let it hang down. There's not much of a reduction that it needs to be performed. It would not take someone to the OR to manipulate them for a closed treatment. You can use this fracture brace. It's commonly available through many companies. Apply acutely or later on. I put a splint on in the ER, have some compression applied. There can be an issue of like, where do you get it? Yeah, you can give somebody a prescription. They can go to a surgical supply store. You can order them online. If you put it into Amazon, Humerus fracture brace, you can go buy one. They're not that hard to find. And then applying a sling initially. Maintaining an upright posture. We are bipeds. That's okay. Give them a sling, allowing the arm to hang down. Close follow-up is important. You're a doctor. They're your patients. You have to see them back. Yes, that I do agree. 1, 2, 4, 6 weeks later, following along the fracture healing and brace compliance. 3 months, 6 months. I think that's fairly routine. I have been quoted, I have my little quotes, yeah, fix and forget. I love that. But in this patient, closed injury, isolated arm, there's no indication for operative treatment. And assessing for fracture motion. I brace until they're healed. I'm weaning from the brace at about 10 to 12 weeks. I think this is the article that was discussed by Dr. Brady, Dr. Driesman, Dr. Eagle was here yesterday. Really, they're looking at 315 humerus shaft fracture patients, 84 all treated initially non-operatively, 73 out of 84, 87% all went on to healing. At 6 weeks is that key point. Treat them non-operatively, see them back at your interval times. You can even tell in the beginning, we're going to treat you non-operatively, and which I would describe as conservative treatment, by the way. And if you have callus and no motion at 6 weeks, and that's not in the radiology suite, that's just physically examining them. The case that he presented of that 2 years of non-union, that lady is going to be grossly unstable when you examine her. Not really painfully, but grossly unstable. At 6 weeks, callus, no motion. They're going to go to union, no callus, no motion. Then I have the discussion of surgical treatment. Initial and pendulum of the shoulder, elbow and shoulder stiffness in these injuries when treated non-operatively is an issue. People do come to see me with their non-operative treatment going on to a non-union. They're very stiff. I think non-operative treatment is not no treatment. Non-operative treatment is a non-operative treatment modality which you have to then treat their elbow and shoulder stiffness proactively. So doing pendulum exercises, elbow range of motion exercises, they are non-weight bearing. It's an isolated injury. If they have a femur fracture, things like that, that's another discussion. But doing active shoulder exercises when the fracture is stable, I send them out to therapy if they desire it after 6 weeks. Just an example, these fractures go on to union. It does work. Here's an example of mine. This was even, I would describe the angulation initially is not all that great. Once the splint goes on, that's improved. Then with the later x-rays, I like to get an x-ray in the brace here. What you're going to see here is the extent of the brace perfectly centered over the mid portion of the fracture. So I know that brace is going to support the fracture as necessary. They're able to get their elbow and shoulder moving. We've all learned this from Dr. Sarmiento. He had his large series of patients. It was the most recent publication is 2000, but large series of patients, some of them even open, with a 6% non-union rate, mostly in the open fractures, but less than 2% in closed fractures, and accepting some angulation, and the outcomes are very good. Even radial nerve palsy is resolved. So we've talked about lots of randomized prospective trials. There is not a randomized prospective trial that's been adequately studied to help us out here. For whatever reason, the clavicle is immensely studied, but yet the humerus is not. So the Cochrane review said there's no evidence available for randomized controlled trials, even though there is some, to ascertain whether surgical intervention in femoral shaft fractures is better or worse than no surgery. So whether they're going to call something conservative or not, I don't think we're there yet. So rather than engaging in a surgery that may be unnecessary, beginning with non-operative treatment, converting when necessary. Why would you do it? All right, vascular injury, floating elbow, additional element, segmental injuries, failing your closed reduction, bilateral fractures, open pathologic. That's not who we're talking about. This is this closed, left-hand dominant, 31-year-old female, neurologically intact. Polytrauma with the humerus fracture, I fix a lot of humerus fractures, but in this patient, that's not what I would support. Bracing is the standard, right? That's what we do. That's what I would describe as conservative treatment. But there are fracture considerations, patient considerations, discussing the options with your patient, remembering who your patient is. This may be not something that you may be desiring of that, the rep may be desiring of that, but for the patient, that's not what's necessary. When you go on to operate, yeah, you're going to have non-unions, you're going to have infections, you're going to have radial nerve palsies. Is that what you want? You've made them worse, right? You started out with a, mildly displaced, if you will, fracture, but now there's an infection and a radial nerve palsy. You've made somebody worse with surgery. There's no as somebody pointed out, there's nobody can be made worse, who can't be made worse with surgery. Here's an example of somebody who came in the morning with a displaced humerus fracture, and then somebody decided, well, let's just fix it that night. We're going to put in a nail, nice and short. Nothing can't be made better with a nail, right? Well, that predictably fell apart, and then the non-union had been sent to me as shown in that prior x-ray. So remember, brace you can brace. There's a lot of people you can brace. We don't need to jump to surgery. These are usually lower energy, isolated injuries, acceptably aligned. You maintain the alignment and brace. Get the fracture to move as a unit at 6 weeks. You know who's going to heal. Get the arm moving to avoid stiffness, and then follow them closely. Thank you.
All right, thanks. So can show the slide real quick. I did post a lot of your guys' papers on the orthoclips.com/10th website. So if any of you want to refer back to that literature that was cited, you can take a look. All right, so I think you saw this multiple times now. Let's vote. I think it was 63% non-operative before. Sorry, okay, start now. I did not hear that Dr. Sarmiento broke his humerus.
God bless him, broke his humerus and lasted 1 week before he had an operation.
Well, we had Dr. Sarmiento here about 5 years ago. Wish we could maybe have him weigh in on the debate. But it seems that
what happened to Sean Nork?
Non-operative.
That is not urban legend. That is truth.